So I'm going to start off this session by talking about kind of the overall perspective of the CDC's work on antibiotic resistance in the context of the federal government-wide effort to combat antibiotic-resistant bacteria. Now, I think it's important to start off by getting a bit of a perspective of the disease burden here. And as we kind of laid out for the first time in our antibiotic resistance report that we issued in the fall of 2013, in which Dr. Solomon actually played a leading role in putting together, we reported that antibiotic resistance sickens more than 2 million people a year, kills at least 23,000 people a year, plus an additional 15,000 people a year from Clostridium difficile. We estimate over $20 billion per year in healthcare costs, and really this problem is a threat to economic stability, and I think one of our most important points that we've been making is that we really need to act now, or even drugs of the last resort are going to soon be ineffective. Now, as part of our report, we ranked 18 drug-resistant threats in the United States after input from a lot of stakeholders and external experts. We ranked them into urgent, serious, and concerning. And the urgent threats include carbapenem-resistant Enterobacteriaceae and Clostridium difficile, and the serious threats included drug-resistant non-typhoidal Salmonella, methicillin-resistant Staph aureus, and a number of other pathogens. Now, we found, since the publication of our threat report in 2013, a building national momentum on antibiotic resistance, which really was galvanized by the development of a national strategy on combating antibiotic-resistant bacteria, and a report of the President's Council of Advisors on Science and Technology that came out in 2014. This was followed by our fiscal year 16 antibiotic resistant solutions initiative that I'll be talking more about in a few moments. Then the government developed a national action plan for combating antibiotic-resistant bacteria. There was a presidential directive that came out along with that. And this has been followed by the White House Antibiotic Stewardship Forum in 2015, and hopefully at least some of you attended. It was really a very, very fruitful and useful interaction. And then another outcome of the presidential order was the formation of a Presidential Advisory Council on combating antibiotic-resistant bacteria, which held its first meeting in Washington, D.C. about a month ago. Now, I'm going to shift to focus a bit on CDC's work in antibiotic resistance. And there really are three core activities across all the different AR threats, healthcare-associated infections, foodborne infections, and community pathogens that characterize our work. And these are in the areas of prevention, stewardship, and surveillance. So in the area of prevention, we develop evidence-based guidelines, we assist in outbreak response, we implement prevention strategies with states and many other partners, and we conduct applied research to inform prevention. Stewardship, which is a very important component of our work, involves first tracking antibiotic use, especially in healthcare settings, and being able to track use and get a sense of how much are antibiotics really being used is really a necessary foundation to be able to improve use, providing research tools and guidance on improving use, and then improving consumer and provider education, which is really a pivotal component to improving stewardship. In the area of surveillance, we implement and use real-time data systems for tracking and quality improvement. This helps us to define risk populations. We provide national and international laboratory expertise, testing and diagnostic capacity, which of course is also very, very pivotal to our ability to detect and respond to AR threats. Now, the FY16 Antibiotic Resistance Solutions Initiative, which is included in the President's FY16 budget at $264 million, It can be divided into three general areas: detect and respond, protect, and innovate. And you'll see how all of our core activities kind of fit into these three general categories. So we're talking about developing regional laboratories, strengthening NARMs, which I'll speak about in a moment. In the area of protect, establishing state antibiotic resistance prevention programs and stewardship programs, which I'll talk about a bit more in a moment. And innovation, understanding the microbiome and empowering our prevention epicenters to develop new strategies using applied research methods. So first I want to talk a little bit more about the protect part of our initiative involving state AR prevention programs. We feel quite strongly that building state health department capacity to address the spread of infectious diseases across healthcare settings and in the community is really pivotal to solving the problem, focusing on antibiotic resistance and also on infection control as a pivotal strategy for reducing antibiotic resistance. The states need to develop core capacity in order to provide regional awareness of threats, to assess and improve infection control, to assess and improve prescribing practices, and to protect patients from AR and also other infectious threats. Now, this is a graphic which illustrates why we think that AR is actually a community problem and why we think state health departments are so pivotal in addressing the problem. And so, essentially, what the graphic shows is how facilities need to work together to protect patients. And it shows how the public health department, as a central node in tracking patients as they are transferred among different types of facilities, nursing homes, long-term acute care facilities, acute care hospitals, so that they can be, as I say, sort of the pivotal point to help us keep track of where patients are and so that we can implement prevention strategies appropriately. Now, in the Vitalsigns that we issued in August of 2015, we used some modeling methods to try to put a little bit of structure and quantitate what the potential impact of using this coordinated approach might be. And we essentially estimated using carbapenem-resistant Enterobacteriaceae, CRE, as an example. We estimated that starting with what you would call a common approach, which would be each individual facility implementing infection control and other interventions in their own facility, and continuing sort of across the spectrum to independent efforts in small groups of facilities, down to a fully coordinated approach with a health department as a central nodal point, we estimated that up to 70% fewer patients would get CRE over 5 years with this fully coordinated approach. So this is a really foundational focus of our FY16 Antibiotic Solutions Initiative. AR is a community problem, and we need community approaches in order to address it. Now, I'm not going to say very much about stewardship because I know that we're going to have two other speakers talking in a great deal of detail about stewardship following me, but I will just mention a couple of or more than a couple, I guess, 6 to 5 to be exact, sort of principles behind how we're approaching improving tracking and prescribing across spheres. So first, we need to improve real-time data about antibiotic use so that we can better understand prescribing. We want to be able to set national standards of antibiotic use so that we can improve use and reduce resistance, ensure that all hospitals have effective stewardship programs, understand and act on state-by-state differences in antibiotic prescribing rates, evaluate and test intervention strategies, and, as I mentioned, create state programs to improve antibiotic prescribing. Now, I do want to spend a couple of moments now talking about another component of the initiative, which is regional laboratories. And a number of objectives of these regional laboratories will be to detect resistance and connections among various different strains that are circulating in the community, to accumulate real-time and actionable information, to support hospital laboratories with confirmation and characterization, to improve outcomes by testing all resistant Salmonella and other resistant foodborne pathogens through NARMS, and I'll talk about that a bit more in a moment, and to integrate the regional laboratories with the state with the Antibiotic Resistance Isolate Bank and National Sequence Database that also is a part of the initiative. So I just want to spend a couple of minutes talking about NARMS, which is the National Antimicrobial Resistance Monitoring System for enteric bacteria, which hopefully is not a stranger to any of you and that you all know quite well. And this is a collaborative system operated by ourselves, FDA and USDA, in which we track antibiotic-resistant foodborne pathogens in people. That's our part of NARMS. In retail establishments, that's the FDA part of NARMS, and on the farm, and that's the USDA part of NARMS. Now, we've actually been already making a number of improvements in NARMS to try to make it more useful, more sort of nimbler, and more relevant to outbreaks. And so one of the things that we've started to do is to report NARMS results routinely with all Salmonella outbreak reports. And so you'll see this on our website as we report on outbreaks that if the organisms are resistant, we're using the NARMS data and integrating this into our outbreak reports. A few other things that you'll see with NARMS, other improvements that we've made recently, is something called NARMS Now, which is a new interactive tool, provides public access to NARMS antimicrobial susceptibility data for Salmonella, for Campylobacter, for O157, and for Shigella isolates from people. These are interactive maps, graphs and tables that are available on our website. And this is a screenshot example of what you can do with NARMS Now. You can look at data by state. You can look at trends over time. You can compare among pathogens. And so it really is a very, I think, a user-friendly and useful tool, and I encourage all of you to go on our website and have a look. Now, what would we do with the FY16 Solutions Initiative funding? Well, the main focus in terms of NARMS would be to enhance surveillance for human infections with antibiotic-resistant Salmonella, starting with Salmonella. As you may know, currently NARMS tests only 1 in 20 Salmonella isolates and 3 strains from each outbreak, usually weeks after illness. So in other words, NARMS really doesn't have broad coverage of what's happening with resistance and Salmonella in the country, and it's not very timely in terms of helping us with outbreak response. So the CARB action plan and funding included in the initiative would allow for testing of all Salmonella from patients in close to real time, which of course will have a number of benefits, including in outbreaks, knowing resistance as soon as the outbreak is detected. And we can prioritize resistant outbreaks for investigation because, as you know, especially with Salmonella, oftentimes these resistant infections are more severe. We can have closer tracking of resistant trends in different parts of the country, in different demographic groups, or according to different Salmonella serotypes, and we'll do better in terms of tracking sources of infection. I just wanted to mention the AR Isolate Bank because this is something that also may be of some interest. We actually launched the Isolate Bank this year with collaboration between ourselves and FDA. It provides collections of bacteria to support research and development of new diagnostic tests and antibiotic drugs. It basically includes curated panels from the AR Isolate Bank, which can be used to challenge and design a next generation of clinical tests and therapeutic agents. The bank now contains over 220 isolates. And we found this to be quite popular. We've already filled 35 orders from various companies just within 3 months of the launch. Now, the last couple of things I just wanted to mention are in the areas of communication and partnerships. As I hope all of you already know, Get Smart Week for this year is November 16th and 22nd. Through November 22nd, I think you'll probably hear more about this from Dr. Hicks. But the goal is to raise awareness of AR and the importance of appropriate antibiotic prescribing and use. It's always been and continues to be increasingly more and more widely used. We'll have a number of enhancements this year, including coupling it with an international component. Also just want to point out lots of tools for partners that are available on our website. These are just a few examples, but we really try to have materials that are ready to be used by partners, and again, encourage you to have a look at our website so that you can make use of materials. We really would like to make these as useful as possible to partners. Last, I think this is last. I just wanted to end with what are the objectives that we've set for ourselves under the initiative are. We've set some pretty aggressive goals and hard outcomes with respect to the reduction in the incidence of a number of infections. And this is a very concrete way of describing the benefits that we see from this initiative to the American people. Just to mention again about our initiative, again, it's $264 million. As I mentioned, there's also an additional $14 million that will go towards improved tracking. We certainly hope that Congress will provide funding as the President has requested in his budget.